All right. Welcome, everyone. Thank you all for joining us, both virtually live in the session and also those viewing the recording. This is Bioethics, Undergraduate Research in Ethics, Health, and Medicine. And it is one of the sessions, part of what's turned into a very nice Research Ethics Day at the Petersheim Academic Exposition. Seton Hall's, for those of you who are calling it from outside, Seton Hall's big research week. And we are especially delighted to have Professor Suli Chang here with us, who's one of the leaders and the chair of the co-chairs of the Petersheim Academic Exposition. So in this session, we're building on work that was done earlier today by a number of leading scholars in research ethics. That session was called Virtues of Inquiry Across the Continuum, the Need for Ethics in Research at Every Level. And what became clear through a number of the talks in the keynote session was the importance of student research. So it really is a joy for me. I'm Brian Pilkington. I teach ethics at Seton Hall. It's a joy for me to be here with these excellent student bioethics researchers, and they're going to present research they're currently working on focused on ethical issues in healthcare, medicine, and healthcare broadly, and also global bioethics. So now, with that somewhat long-winded and less interesting introduction than the sessions we're about to get to, I'd like to turn the mic over to Rishi Shah, who will introduce himself, explain his project, and share some slides with us as he talks through what his work is. Rishi, you should now be able to share.
I am. Can you hear me?
Yes, we can hear you well.
Oh, great. Okay, perfect. So I am going to screen and then perfect. You guys gonna see my slide, correct?
We can.
Okay, perfect. Well, welcome everyone to my presentation. I titled mine Unity and Care, a Catholic Perspective on Healthcare in America. My name is Rishi Shah. I am a junior biology major with a minor in medical humanities. And what I want to do with my presentation today is actually not focus on bioethics, but strip it back down to the basic roots on what could we be basing our bioethics on, in this case, a Catholic perspective. For background, as I present to you the history of Catholicism's involvement in healthcare, I'm a practicing Hindu. I'm not even Catholic myself, but during pursuing my minor in medical humanities, I've gotten a chance to read a lot of Catholic papers and Catholic takes on certain healthcare issues. And what I found is that there are a lot of similarities within Hinduism and Catholicism that I really appreciate. I call them universal qualities. And why? So for me, I found a bridge between that. And today I want to try to present a bridge to you all, because I think it's really important to understand different people and different patients' perspectives and religions. And once you're able to accomplish that, then you are truly able to provide the best care. So with part one, I actually want to look at some biblical and historical quotes that find in Catholicism that relate to healthcare. And I want to start off with biblical texts. As you can see, I've listed them and you can read them yourself. But the important thing that these these texts show is the importance of human dignity. In each one, it's always emphasized, and these patients are not talked about as patients, but they're talked about as people with certain ailments. And I think that distinction is really important, because what it does is it tries to emphasize that they're people, right? That they're the same brother under the common fatherhood of God, right? And I think that's very significant. Whether it's the woman that Jesus cures on Sabbath day, or it's acknowledging the compassion that these people have, or it's sending his disciples out to go and heal the sick. It's always done to ensure human dignity. And I believe that to be an important first principle of a Catholic basis in healthcare, which I'll talk about. And the second basis I'll be talking about is solidarity. And with solidarity, I think Bishop Dionysius's self-reflection on mental health is really important. And in here, he talks about how physicians and professionals have a burden that they take on as they diagnose patients and help treat patients, because you're really dealing with life and death. And is that burden really meant for human beings? The burden of holding someone's life in your hands? And very many can say no. But the important thing to take away is that we have a solidarity. Every action we do, everything we provide as providers, will impact not only the patient in some way, but ourselves and our mental health in some ways. And finally, in regards to my third principle that I'll talk about, the common good, I want to take you guys to Pacem in Terrace, where Pope John Paul says, in consequence, he has a right to be looked after in the event of ill health. And here he's asking the question, what rights do humans even have? Well, the Catholic faith would suggest, in relation to the United Nations Declaration of Human Rights in Petersheim and Terrace, that the right to be treated in a healthcare setting, no matter who you are, is a right. You have a right to healthcare. And we'll see that when I talk about the common good. So moving on to the proposal, and I base my proposal off the Catholic Foundation cited in that article, which is also in the bibliography that I'll provide later. Again, the first quality that I talk about is human dignity. And that's a call for respecting any person as a brother under the common fatherhood of God. But what does that mean in terms of treating patients? Well, a Catholic bioethics perspective would say a desire for more holistic reviews. You'll see a lot of push from med schools nowadays for more holistic reviews and not just focusing on tests, because socioeconomic factors and especially environment factors have been found to really contribute to diseases. For example, where do they live? What kind of access to food do they have? What kind of education do they have? Like, preventive measures, things of that nature. And the other thing with human dignity is understanding Catholics would argue that the body is a gift from God. And with that, you need to be sure not to abuse it. One, that would be not over testing, for the sake of, I found healthcare professionals talking about CYA when I've shadowed, right? And, obviously I won't repeat that, but, if you know, you know. And because of that, they start to over test when it's not even necessary because they're worried about something. And it's important not to abuse the body to extra radiation that may not be necessary. But along with that, it's important not to under test either. And using the available technology is justified in returning man's dignity to what it was prior to sickness. So keeping human dignity in mind was very important. Along with that, solidarity, again, stressing the importance of how the professional, the provider, is also affected with every patient that they see. And so it's important to be more intentional. I found that providers don't often note that they were reviewing patient charts during each patient report. I think that should be noted so that there's a clear intentionality that they are caring for this patient and that patient is part of their own life, and they're recognizing that through mentioning the charts. And along with that, it would be recommended through this Catholic perspective that they have mandatory meetings with psychologists, and I know some have started to incorporate that, but I think that should be mandated for all healthcare professionals. And finally, with the common good, you can look to no further than the Good Samaritan. And man should act on the basis of helping anyone out of altruistic intentions. And this, obviously, like I mentioned, Petersheim Terrace leads to quality healthcare and universal healthcare, aligning with the WHO's plan for 2030. And so these three perspectives really embody what a Catholic perspective in healthcare would look like. Finally, with part 3, bioethics is based on Beauchamp and, primarily on Beauchamp and Childress's principles used by most bioethicists. And I just wanted to show you some relations with the Catholic faith. So with beneficence, defined as the act performed to directly benefit others, that obviously relates to the Good Samaritan. And with non-maleficence, it relates to St. Thomas of Aquin's double effect, accounting for the side effects that may not be positive, may be negative. But if the overall good, a more Mills approach, exists, then the procedure may continue. Along with that, there's justice, the fair distribution of goods, and in healthcare, you'll see distributive justice. Again, that aligns with the common good principle that was proposed. And finally, the final principle of autonomy, the right for patients to make their own determination. It can only be accomplished, right? Patients can only have autonomy when they're respected, and all the information is provided to them by providers, and nothing is hidden. And with that, I have my bibliography, and I just want to really stress, as I say, thank you, that only when we start to make connections between religions can we properly analyze the ethics behind each case. And once we do that, we'll be one step closer to being more united as a society and more united to providing a stronger patient treatment. And with that, thank you so much, and have a wonderful rest of your day.
Rishi, thank you. That was excellent. The human dignity line is music to my ears because I'm very interested in that concept and the benefits for reflection on it for bioethics. But really, a tour de force, bringing together different religions and highlighting potential sort of places of agreement. So really, really nicely done. For those of you who have hopped in just now, after each presentation, we'll take 2 or 3 minutes for a question or two, and then we'll have much more time at the end for Q&A. So I have a ton of questions, but is there anyone, any of the other presenters or anybody in the audience, just raise your hand if you have a question for Rishi Shah. And yes, Lisa Rose Wiles, who is one of our wonderful librarians here at Seton Hall. Lisa, the mic is yours.
Oh, thank you for the plug, Rishi. That was lovely. One of the things that it occurred to me rather cynically, because my husband's disabled and has a lot of medical appointments, and always practically the first thing they ask you after your date of birth is what insurance do you have? Is all your insurance up to date? And 15 questions follow about your insurance and so on and so forth. Recognizing that this is a medicine for profit country and healthcare system, unfortunately, is there any way that you can think of that we can get people more on the same page about like not making that the absolute priority when you're greeting somebody at a doctor's office or any kind of medical facility? I don't know if this is everybody's experience, but it's certainly been mine. And it sets you off on the wrong foot, so to speak.
Right. So I can speak a little bit. So I'm a pre-hospital provider. I'm an EMT. And before I ask my patients any questions, the first thing I do is, before asking them what their name is, I introduce myself. I think what lacks nowadays, and you'll see it in the OR or you'll see it in the ICU a lot, is a lack of personability. And that's something that you've been describing as well. And it's the basic things. It's saying hello. It's introducing yourself. It's whenever the patient is explaining an experience, it's trying to relate to them in some way. And part of the reason I want to go into medicine is because my desire to relate with these patients when they're vulnerable. It's the small things. And while I say that, there is no easy fix to that, because it's more of a statement on our society and the capitalistic society that we live in. There's a twofold answer to this, and one is, again, a more conscious effort to send bioethics to all the providers and have them go through trainings, because there needs to be that change in communication from the very onset of when you enter an office. And the second thing is a restructuring of the finance system, because insurances only pay providers about 10 to 30% of what they're actually owed. So they're always consumed by money because they're not getting as much money as they're expected to be. And so finding a better balance of how insurance does its payouts will then help alleviate the stress that also causes even more lack of personal ability. But it's twofold, and it's a long-term thing. It's not a short-term thing. So I do not have a short-term answer for that. But long-term, that is the way that it needs to be approached.
Okay, thanks so much. As you said, it doesn't seem like a huge thing, almost symbolic, and yet it does have a huge effect.
No, it does. It does. I mean, as a student, right? When the teachers I really have come to appreciate versus the teachers, I may not go back to. I can tell from the very beginning, from the way they introduce themselves and the way they get to know me as a human. And it makes the world of a difference. I take my grandmother to appointments, and I have some doctors that I'm not fond of and some doctors that I am fond of. And it's the ones that let her get to talk about, don't cut her off. Let her listen, let her explain her entire story, acknowledge everything. It's the small things, but it's more of a statement on the panic on the way money is coming in. And so that has to be addressed first. Thank you for your question.
Rishi, a super helpful response, and no surprise that you're both a practicing healthcare professional and also sort of deeply steeped in bioethics. I'm going to save my plethora of questions for the end. We do have about 1 more minute before we go to the next presentation in case there are any other pressing questions. If not, we'll march on. Wonderful. Rishi, thank you so much. And I think the explanation, especially in response to Lisa's question, was really helpful and helpful for me to reflect on. I know there are, since you're interested in medical school, some forward-looking medical schools who are actually offering electives related to all sorts of finance concerns. And I know that there are leading medical educators in this area. So yeah, I'm sure you will join in this effort and fix things. Well done. Thank you. We're now going to turn to our second presenter, Chabela Bonilla, and I'm just going to, you should Chibeli have the ability to present? And go for it. Please share your slides. Wonderful.
Can everyone see?
Yes.
Awesome, awesome. All right, so we shall begin. Thank you so much, Dr. Pilkington, for the introduction and for inviting me here today. And a good afternoon to everybody. My name is Chibeli Bonilla. I'm a senior here at Seton Hall, and I'm an anthropology major. And today my topic is going to be reprocessed medical equipment through the bioethical lens. So before we begin, I have to preface by saying that this presentation is kind of like a summary or like an excerpt of an upcoming public health paper titled Conceptualizing the Life Cycle of Environmental Impacts of the Life Cycle and Environmental Impacts of Reprocessed Medical Equipment. It is written by an amazing research team that I've had the pleasure to be a part of since last spring, I believe. We're called Reprocessing Medical Equipment Rotarian Research Group for the Environment, also known as REMERGE. It is a subgroup of the International Rotary Fellowship for Healthcare Professionals, and it consists of me and 3 other students, Bruce Meng of University of Texas at Austin, Rose O of Queen's University, and our wonderful research lead, Jennifer Orth, here at Seton Hall. She will actually be presenting later. So without further ado, let's begin. So the following research dissects the interrelationships of donating reprocessed medical equipment, namely here in the United States, something that is deemed to be at the end of its life cycle, something that is broken, unfixable, and the ethics behind donating such medical equipment to a low-income nation, all for the sake of humanitarian efforts. Defining reprocessed medical equipment. Reprocessing medical equipment describes the process of sterilizing, disinfecting, and possible remanufacturing of a piece of equipment, either back to the Food and Drug Administration, the FDA, or the original manufacturer for reuse. The equipment itself can be deemed to be at the end of its lifetime. An example of a reprocessed device would be an old school analog X-ray produced by General Electric being sent back from the healthcare facility to either the manufacturer or the FDA for remanufacturing into a more modern digital X-ray. Even a CT scanner going back to the original manufacturer for decontamination or just for disinfecting is also considered a reprocessed device. And a reprocessed device can also be reprocessed just for the purpose of donation. So the current issue at hand, there's currently a state of inadequacy for reprocessing medical equipment with very little regulation on a global universal scale. When we were conducting this research, this raised the question that if this was even all ethical, why are you donating a piece of reprocessed medical equipment that is deemed non-functional? Why is that ethical? It raises questions also like why is something that is considered at the end of its life or not standard in the USA okay to be donated to a low-income country? Should healthcare providers ensure follow-up care with reprocessed devices? And will the standard of care be affected? So when we're talking about bioethics, there's 4 pillars of bioethics. According to the University of Washington School of Medicine, the Department of Bioethics and Humanities, they are defined as follows. So autonomy is decision-making or the practice of informed consent. Non-maleficence is to cause no harm to patient. Beneficence is the obligation that healthcare professionals have to be of a benefit for the patient. And then finally, justice, fairness, and equality. So the bioethical solution. So while I was conducting this research for the paper, I actually reached out to Dr. Pilkington to get his expertise on this topic and possible solutions and how we can take the 4 pillars of bioethics into consideration. So the first question is, what is the moral obligation to others when donating medical equipment? With this question, first we must address the following. Does the medical equipment need to be cleaned? Is the equipment meeting the best practices or standards or levels of care? Is it to be donated to a specific population or to the entire world? And if healthcare facilities donate, let's say, a ventilator, they should make sure that there are also resources available for the said donated ventilator and ensure follow-up care. The next question is, as non-maleficence is a pillar of bioethics, should healthcare providers, professionals, or facilities themselves have the same mentality of, quote, first do no harm, unquote, when donating reprocessed medical equipment? So if non-maleficence is the main obligation, as opposed to the three other pillars of bioethics, what would end up happening is that fewer medical equipment, reprocessed medical equipment specifically, would be donated. That way, you're at least ensuring that the few that are donated are super effective. When you take this question and compare it to the pillar of beneficence, they may be thinking, like healthcare facilities may be thinking that donating a bunch of medical equipment is much more effective. It's going to help a lot of people. But out of, let's say, the thousands of medical equipment that was donated, there's a few that are defective. Eventually, that's going to cause some harm, even though that's not the intention. Finally, when following non-maleficence, or really taking that into consideration, one must recognize that they're potentially helping less patients in order to ensure that they're not hurting other patients unnecessarily. Ultimately, under non-maleficence, causing unnecessary harm to patients is far, far worse than not benefiting from many patient use. And finally, what follow-up care should providers ensure when donating reprocessed medical equipment? When donating reprocessed medical equipment, providers and facilities alike should be sure to provide follow-up care and resources and all tools necessary. Providing proper gear and knowledge on how to use said equipment, or even providing technicians or medical professional personnel that know how to use it, would be amazing. And any medical equipment that does not have a follow-up care or resources or anybody who knows how to use it properly or ethically is not really considered effective care. And to conclude my presentation in brief, no one in this world deserves equipment more than the other just based off where they're living, whether a high income, middle income, or low income nation. Patients should have the right to efficient and satisfactory equipment and care. Donors must ensure that proper standards and regulations are being met to protect the patient's well-being. And finally, bioethics should be a prioritized topic when discussing donating reprocessed medical equipment. Here are my citations, and thank you very much to everybody.
Chibeli, thank you so much. That was excellent. Yes, Jenny's giving, everybody's giving virtual class. Wonderful. And I'll say before I open the floor for questions that though in general I have some concerns about the four-pillar approach, the most interesting work that happens is exactly what you just did in terms of taking two of the principles and trying to understand and balance between them. I mean, that's the real interesting stuff. And it's always wonderful to have an anthropology major. I mean, the diversity of this session of bioethics is actually, we've got philosophers, anthropologists, healthcare folks. It's great. So I have tons of questions, as always, but I'll try to save them for the end. So anyone in our audience or any of the other presenters, so I don't talk too much, questions for Chibeli about the Remerge project and about her work on the ethics of this. Yes, Jenny saved all of you from my list of questions. Go ahead.
Sure. So, I mean, I guess I know part of the answer already, but just for this, for other people, so you say that you have to, I guess, prior to reprocessing medical equipment, you have to take certain protocol to make sure and ensure that the equipment is up to code so that it can be donated to other people for use. How do you, like, what protocols are in place and how can you ensure these protocols will be followed to a T? Like, is there any, I don't know, maybe like legal or like, I'm not too sure, but social implication to it?
Yeah, thank you so much, Jenny, for your question. So it really depends. So I do know for a fact that the World Health Organization does have like guidelines on what to do and how to reprocess medical equipment. What are the standards behind it? What are the practices? Not every healthcare facility follows the World Health Organization. So what they end up doing a lot of the times is they'll actually do third-party vendors. So let's say a medical surplus recovery organization. There's one called Med Surplus Alliance. If a facility were to donate something through that MSRO, they have to follow that MSRO's code of conduct. I'm going to assume that other third-party vendors have their own code of conduct or their own guidelines on what to do. So for, let's say, the Med Surplus Alliance one, which is the one I actually did the research on, let's say they have to, part of the code of conduct is it can't be like broken, it can't be, it has to be disinfected, it has to have technicians with coming with the piece of equipment. It can't be something that is too large or something that is too small. There's every company, third party, even the WHO, the World Health Organization, has their own code of conduct and guidelines that they have to follow. So it's a pretty broad question, but I hope I answered justice.
You did. Thank you.
Thank you.
An excellent question. And someone else saved you from my question. Vanessa, who's raised her hand. Vanessa, please.
Hi, can you guys hear me?
Yes.
Oh, so sorry. My microphone is really weird, so it might cut off. If not, I'll just ask my question in the chat. But I just wanted to know what got you into this topic in general, because in today's society, we're pretty big on like recycling and stuff like that because of what plastic uses have gotten us through this and generations as in late. But it's like really interesting. No one, at least myself, I never considered medical equipment to be recycled and reused, although it's a very like profitable in this expecting of like people can actually acquire this and actually have opportunities to better themselves, although medicine is always evolving and we're always getting like the newest technology. It's just a very interesting topic that I never thought it was really a thing.
Yeah, thank you so much, Vanessa, for your question. So last year, I was recruited to join the Remerge group, as I mentioned in the beginning of my presentation. So it's a research group, and we were just looking into the life cycle and the environmental impacts and carbon footprints and whatnot of said reprocessed medical equipment. So while we were conducting that research, I actually spoke to the radiology department director at Mount Sinai Beth Israel. His name is Mr. Harold Rodriguez. He's a wonderful man. I had the pleasure of interviewing him last year. And while we were talking, he mentioned that sometimes it's unethical to use a piece of medical equipment for anything other than its intended use. So that really got me thinking, and I really wanted to add a section of bioethics into our paper, and thankfully Jenny agreed, and so we kind of got onto it, and I reached out to Dr. Pilkington as well, and he was on board as well, and that kind of snowballed into where we are now. But yeah, that's pretty much it. I think it's important to know like what are the ethics behind all of this as well. I think it's important not only as like healthcare professionals or students or academics, but as the public, as patients, you should be aware of what's going to happen when the medical equipment is no longer, usable, or if it's to be reprocessed. What are the ethics and what are the protocols to be taken? I think that's what started all this. I hope I answered your question.
Yeah, definitely. Thank you so much for answering.
Thank you.
Excellent, Chabeli. Thank you so much. We are now, and there's people adding some comments in the chat as well, but now we're going to transition to our next presenter. Wonderful job. Thank you. So our next presenter is Brandon Hammond, and I will give you, Brandon, you should have the power to present, and now you should be the focus of all of our attention. So please go ahead and begin.
Thank you, Dr. Pilkington. I'm just trying to pull up my slides here. Okay, everyone can see my slides?
We can. Excellent.
Okay, great. Thank you. So thank you, Dr. Pilkington, for the kind introduction. As Dr. Buchan said, my name is Brendan. I'm a junior biology major here at Seton Hall. I'm on the pre-med track, and today I'm going to be giving a presentation on ethical considerations of adolescent bariatric surgery. So you might be wondering what sparked my interest in this topic. So last summer, I had the opportunity to shadow a bariatric surgeon up at New York Presbyterian Hospital in New York City. And while I was there, I noticed several ethical issues that arose with between patients, between parents, and between surgeons. And I wanted to explore the issue further. So this is what prompted me to want to do research on this topic. So just as a general introduction, adolescent bariatric surgery is a medical specialty that involves the treatment of adolescents for severe obesity. In 2018, the prevalence of obesity in the United States was 21.2% among adolescents ages 12 to 19. So that's roughly 1 in 5 adolescents are obese, which is a big number, and it's growing. So what ABS attempts to do is prevent obesity-related illnesses such as cancer, diabetes, fatty liver disease, and heart disease. And the current surgical options for ABS include gastric sleeve, the gastric bypass, and the gastrectomy. The most common one we see today is the gastric sleeve. So there are very specific qualifications for ABS. Usually you need to have a BMI over 40 in order to qualify for surgery. In other cases, you can have a BMI over 35, but you need to have other comorbidities such as hypertension, diabetes, fatty liver disease, etc. These qualifications are necessary, obviously, because not everyone can get the surgery, right? It's obviously healthier to lose weight by diet, by exercise. This surgery should really only be a last resort. So while there has been a significant amount of research on the ethical considerations of bariatric surgery in general, there has been relatively little research into ABS specifically. So now I'm going to discuss sort of my research aims and where I'm going with this. So I'm aiming to explore the ethical considerations that arise with respect to ABS. So patients who undergo ABS are typically before the age of consent. They're below the age of 18. So they cannot consent to intervention without their parents, obviously. So this raises a ton of ethical issues, which we're going to get into. So I argue that while surgical intervention may be a logical treatment option for certain groups of patients, it is necessary that the risks, benefits, and alternatives are discussed between patient, parent, and surgeon. And this is what is known as shared decision-making. Now I made this chart, which summarizes sort of the ethical issues associated with ABS through my own experience and found in the literature as well. Did a literature search, and I found that bullying and peer pressure is a major issue when it comes to ABS, because a lot of adolescents, they're bullied in school, they're peer pressured, and this sort of plays a role in their decision to seek medical intervention or surgical intervention. And it sort of raises the issue, like, is it the child's decision to get the surgery? Is it a friend who's sort of this like external locus of control, or is it an internal locus of control? So here we have physician bias as well. So sort of these biases that physicians might hold, right? Like regarding the ideal body weight or the ideal body image. Is the physician sort of prompting the child to get the surgery, or is it really coming from the child? So it's sort of this autonomy issue we're going to get into as well. So we see here as well parental bias. So is it the parents who are forcing the child to get the surgery because, maybe the parents have this sort of, this ideal body image that they want for their child, or is it just the child? And furthermore, we also see here the influence of social media, especially today, right? Like through Instagram and, all these Facebook. Adolescents are exposed to social media way more today than ever. And this can affect, they see an ideal body or something they idolize on social media, and that would potentially prompt them into seeking surgical intervention. So now we're going to discuss sort of how this relates to bioethics and some key bioethical principles. So, first we're going to discuss autonomy. So adolescents should have the autonomy to make decisions regarding their body. And of course, informed consent should be upheld. So, the risks, benefits, and alternatives of surgery must be discussed prior to any decision being made. And then it should ultimately, in my opinion, be the child's or the adolescent's decision combined with the surgeon and the parents sort of making a combined decision before to seek treatment. Following that, we also have the Kantian approach, right? So Kant believed that we sort of have this moral duty to prevent illness. And in relation to this specifically, once a child has exhausted other means of trying to lose weight, right? Like, let's say they've tried exercise, they've tried dieting. Maybe they might seek something like ABS, and Kant would support this. Also, we have here beneficence. So ABS as a treatment option only when diet, exercise, and other natural means of weight loss have failed. And after that, we have non-maleficence. So do no harm, essentially, right? So obviously the surgeon can't do any harm. They have to consider the benefits, the risks of surgery, and it's especially important when it comes to ABS. With any surgery, you need to consider the benefits and the risks. But like I said, combining all these factors together in ABS, it's especially important that all of these ethical principles are considered. And then finally, we have SDM, so shared decision making. We need the parent, the patient, and the surgeon all to come to a unanimous decision that reflects the beliefs and values of all three parties. So in conclusion, a specific set of criteria for surgical intervention must be established to minimize the risks of surgical intervention in adolescent patient populations. Because ABS patients have not reached the age of consent, it is necessary to consider the influences of peer pressure, bullying, social media, physician bias, and parental bias on ABS treatment decisions. And this ensures that an ethical treatment decision is reached, which encompasses the values, thoughts, and beliefs of patient, parent, and physician. And here I've listed my references, and thank you guys very much.
Brendan, thank you. That was wonderful. Again, I have a host of questions. We'll see if anyone saves you from my onslaught or not. But if there are any, no, it was really, really good. And sort of very timely as we've come out of the 20th century, which was known, with apologies to the practicing physicians on this call, known as the century of the surgeon, right? So there's a ton here ethically, and really, really nice job. Any questions from any of the audience members or any of the other presenters? Yes, Lisa Rose Weil.
I'm going to save you again. So I'm wondering, with this bariatric surgery and so on, is there any data on the side effect, like the failure rates of these surgeries, just what kind of risk they are? I'm thinking, particularly for adolescents, there must be a lot of vulnerability there.
So yes, there is data in the literature that suggests that there are side effects potentially down the line, typically in the age range of, if you're getting it as an adolescent, right? Typically in the ages between 50 and 60, you might have some sort of, maybe a staple issues, or there's been issues documented in the literature in terms of malpractice and things of that nature. But typically you see great results with ABS. You see weight loss typically within the first 3 months from what I've understood. And, these patients are followed, throughout like the first year, they have follow-up treatments with the follow-up appointments with the physician 6 months, 12 months, 18 months, etc. And you typically see great progress.
So it's not really a risk issue. I mean, I can certainly see the temptation for a quick fix, right?
Right, correct.
Thanks.
Excellent. Thank you, Lisa. Another great question. It's always good to have librarians in these sessions because you don't get away with anything, right? You have to make sure your literature review is up to snuff. So well done. Thank you very much, Lisa. We have one more hand. So Brendan, you get one more question before we jump to Jenny Orth. Vanessa, yes, please go.
Hi, I just wanted to thank you for your presentation. It means a lot. I grew up actually as a child with obesity due to a health issues that I had, and throughout my life I was like that kid that hated to go to the doctor because I was careful about my weight and I always fluctuated. And I wish there would have been more information about this because my weight was sort of concern for my family. But although I could not control it because it was a side effect of medications that I was taking throughout my life as throughout childhood. So the way that I acquired was something it was like my doctors were like, okay, at least you're okay now. You can lose the weight. And I could never lose the weight because of X, Y, and Z. So having this now is like, I see myself in kids that now have options because some of the times some people think that obesity is like a choice. Most of the time, I'm not speaking for everybody, but personally in my scope of view, people think that obesity is like, oh, you choose to be obese half of the time. And I see hope for kids like me. Now that I'm grown up, I see hope that people are actually listening to what's going on to us instead of seeing like, oh, eat less and stuff. So I wanted to thank you. That was really, it really impacted me. So thank you.
Thank you.
Brendan, thank you. Excellent presentation. Vanessa, thank you very much for sharing that. There are often times when bioethics touches on us personally, and not everyone is able to sort of share things that are deeply impactful to them. So thank you very much for being here, and thank you for sharing that. We're now going to turn, thanks, Brendan, to our final presentation of the day. For those of you who saw the earlier posting, one of our presenters, Navya Guti, is unable to be with us due to some health concerns. So we have our final presentation of the day, and then we'll turn to Q&A. So Jenny, you are up.
Sounds great. Y'all can see my presentation?
Yeah, yes, we can.
Perfect. Okay, so good afternoon, everyone. My name is Jennifer Orth. I'm a biochemistry and philosophy double major at Seton Hall. Did I say I was a junior? I'm a junior, by the way, if I didn't mention that. Anyways, before I start my presentation, I just want to thank Dr. Pilkington for having an opportunity like this to present our research over the past year that we worked really hard on, and it gets some recognition, so thank you, Dr. Pilkington, and thank you to all the guests that decided to listen in on our presentations today. So thank you. Without further ado, I'll get started on my presentation, which is epistemic considerations of forced sterilizations. The Human Rights Watch defines forced sterilizations as when a person is sterilized after expressively refusing the procedure without her knowledge or is not given an opportunity to provide consent. This practice infringes upon a person's rights and autonomy. In the modern world, people with female sex organs are the most likely to have forced sterilizations performed on them. Forced sterilizations is neither a new practice nor something that has been left behind in history. In the fall of 2020, a whistleblower claimed a for-profit ICE detention center forced sterilization procedures on immigrant women. The question that I now ask is whether forced sterilizations are morally justified. While the obvious answer seems to be no, I hope to show that with a contextualist account, the moral justifiability of forced sterilizations can differ to varying degrees. So this brings us to the question of just some technical terminology. So feminist epistemology. So we'll take the first part of the word, epistemology. Epistemology is the study of knowledge. Knowledge is based in truth. Contextualism, specifically, is a way that allows several different theories to count as versions of that position. In other words, certain scenarios can alter the idea of knowledge / our truth. Feminist epistemology is a branch of contextualism that places value on women's access to knowledge. I argue this is not always necessary. It can help, but it can help evaluate different questions, such as when forced sterilizations can be justified. I now proposed a few scenarios to see how and when under certain contexts such a controversial topic can be justified. Scenario number 1. A doctor performs a forced sterilization procedure on a female with a life-threatening condition such as ovarian cancer. Person Doe was in a car accident and is brought into an emergency room without any identifying documentation and is unable to communicate their thoughts. The doctors take an MRI to assess the damage. As the results come in, the radiologist identifies a mass in their ovaries, diagnoses it as stage 2 ovarian cancer, and recommends an immediate hysterectomy to prevent the patient from dying of their injuries. In this scenario, a sterilization is forced as it was performed without the patient's consent, but the best available medical judgment was that the procedure was necessary to save the patient's life, and that delaying to get consent would significantly increase the danger to that patient. Here, any social, political, religious, and so on views or dispositions of the operating surgeon are irrelevant. Scenario number 2. A sexist doctor performs/considers a forced sterilization on a female with a non-life-threatening condition. So I break this down into 2 versions. So the first version, version A, Dr. Sexist A performs scenario number 2. First, suppose we have Dr. Sexist A, who is similar to the OBGYN who performed hysterectomies on ICE detainee females. The reason it constitutes as sexism is that, to our knowledge, no males had sterilizations performed on them. Version B. Dr. Sexist B considers performing scenario number 2, but eventually rejects it. A second case we should consider is a sexist doctor who does not commit malpractice. Dr. Sexist B follows all the proper protocols. The difference between Dr. Sexist A and B is that Dr. Sexist A allows predisposed discriminatory beliefs to guide their medical judgment, whereas Dr. Sexist B follows precedents and considerations of bioethics, such as following the Hippocratic Oath. Even if Dr. Sexist B had a passing thought of performing forced sterilizations on females, they would not perform a surgery unless it accorded with the basic ethical principles of doctors' responsibilities to uphold duties such as patient autonomy and non-maleficence. Scenario number 3. A feminist doctor rejects performing forced sterilizations on a female with a non-life-threatening condition. Now that I've proposed all the scenarios, let's compare the cases. The outcomes of Dr. Sexist A and B are different. However, there is a crossing of similar philosophical patriarchal paths. The differences lie in the values they decide to take into the principles that guide their respective actions. Consent was not given in either case. However, only Dr. Sexist A violated a patient's right to autonomy and informed consent. Dr. Sexist B did not act on any sexist predispositions, thus not violating the right of the patient. Considering Dr. Feminist, opposed to Dr. Sexist A and B, ideally permits an easier rejection of forced sterilizations. Comparing Dr. Feminist and Dr. Sexist A shows both their thought processes and conclusions are different. Dr. Feminist recognizes and respects the patient's right to have informed consent, autonomy, and non-maleficence, whereas Dr. Sexist A does neither. It was unjustified for the OBGYN to perform forced sterilizations on females because Dr. Sexist A let their discriminatory predispositions to sexism guide their judgment as a doctor. Although both Dr. Feminist and Dr. Sexist B conclude forced sterilizations are wrong on a shared loyalty and practice of the Hippocratic Oath, that Dr. Feminist does not have any sexist hesitation to reject performing a forced sterilization because they would advocate for the right of the female's body and voice. This then leads me to analyze these scenarios on contextual analysis. So on the grounds of contextualism, viewing the patient as a female's body and voice or as a patient's body and voice changes the moral justification and conclusion of what happens to the patient. Depending on the context, consent and a feminist/sexist predisposition are not necessarily needed. So for instance, in scenario 1, that shows a world where the patient is a person with a life-threatening condition and the doctor must help save a life. However, the 2 cases presented in scenario 2 suggest that even 2 sexists can live in different worlds depending on whether they act on their values as a sexist or as a doctor. Scenario 3 showcases the importance of a feminist lens as they not only reject forced sterilizations, but there is also no sexist hesitation that occurs when justifying their beliefs. Scenarios 2 and 3 require consent as they both have conscious patients and non-life-threatening conditions. Contextualism helps frame various scenarios with different justifications and conclusions. With that being said, I'd like to now move on to feminist standpoint theory, which is a part of epistemology. So the standpoint theory focuses on how starting out starting thought out from the lives of the marginalized will lead to the development of new sets of research questions and priorities, and allowed for the for the oppressed to enjoy certain epistemic privilege that allows them to see problems differently. Social location is a key factor in holding an epistemic advantage. A female's life can provide additional insight to help generate a more complete, less partial, and more objective knowledge base. However, feminist standpoint theory is not the only way to achieve such advances in medical professional/patient interactions. As shown in scenario 1, the doctor does not need to begin with a marginalized identity to understand the necessity of saving a life. The standpoint theory ties to the issue of coerced sterilization, specifically of scenarios 2 and 3, as follows. If we begin with the feminist, it allows for a deeper understanding of the life-changing enormity of sterilizations and its strong attachment to rights. They are automatically at an epistemological advantage over the sexist, as they would take into consideration the bioethical aspect of viewing the patient as a female patient rather than just as a patient. Scenario 2 and 3 above show the last slide, show the importance of incorporating feminist perspectives into patient care, both to combat sexism in medicine and to support recognition by the medical community at large of the personhood of each patient. Future research-wise, I propose to implement an increase in bioethics and EDI education in medical schools. With an increase of both, it could help diffuse personal sociopolitical opinions such as sexism out of the scientific realm of judging life or death. With more training, it could have significantly decreased the likelihood of female ICE detainees losing their human dignity and rights to autonomy, along with an organ they never consented to having removed. Thank you.
Jenny, thank you. That was excellent. And I will again, yes, we have claps from the audience. I will again defer to audience members, though I will say it's been really hard in each of the sessions. It's especially hard when someone gives a philosophical argument. So if there's anybody who wants to jump in, please do so and save Jenny from dealing with my cranky philosophical questions. Chabeli, yes.
I have to run, but great presentation. I have to be elsewhere.
Many thanks for attending. Petersheim week is yes,
insane.
Very, very heavy. Very, very heavy. Thank you, Lisa. Chabeli, please.
Okay. Hi, Jenny. So first of all, really wonderful presentation. I really enjoyed it. I like how you mentioned talking about like the ICE holding the, I'm not sure what to call that. I'm so sorry. The ICE detention centers, I guess that's the proper term. I like how you talked about that, because I actually I think that was like a couple of years ago that broke news. A whistleblower, a nurse who was working there, talking about these awful operations going on. Besides that, is there anywhere else that you can implement like this type of situation? Like it doesn't have to even be like with feminism, more for like minorities or people. So sorry about that. That was my oven. So how can we implement this theory, not just with feminism, but more for like people in marginalized communities or people in people of color, people in low-income nations? How can we implement this as well?
Absolutely. Thank you for your question. So feminist epistemology, I don't think is necessarily limited to just speaking on behalf of women's, knowledge base. So standpoint theory is basically it's a theory part of epistemology that says, if you start at one, if you're marginalized because, for instance, right, I'm queer, I'm a person of color, I'm also a woman, right? All these different things define me, and that gives me an epistemological advantage. So I get more knowledge in terms of my social location helps define the epistemological privilege that I have in this realm. So the importance of feminist epistemology in conjunction with standpoint theory allows me, not only me, but just anyone who wants to advocate as a feminist epistemologist to rebuild the history of what we consider knowledge, right? So, in the past, I think the easiest example for us science people to understand is like Watson and Crick. Watson and Crick was attributed, they created the knowledge of X, Y, and Z. And that was the historical like precedence of, they created the DNA model and whatever, right? But then it was later revealed Rosalind Franklin actually created that. So why is that relevant? Because historians at some point went back and were like, no, let's get this history right. That was not the knowledge of like, well, this was actually not a great example now that I think about it, but the premise is still there, regardless of, whether you are a man or a woman or, someone who's gender nonconforming in terms of feminist epistemology, if you claim feminist epistemology, then that means like using unique lenses, specifically a woman's lens, creates different knowledge from what the original intent, or I guess the traditional male gaze intent was. So hopefully that explains it.
That was brilliant. Thank you.
Excellent. Excellent response. A great question, Chibeli. Any other questions for Jenny before we open it up to a broad Q&A? All right. So now we're going to open up, and I will take the moderator's prerogative and probably go run backwards through the session. So Jenny, you're not quite off the hook yet. All the presentations were great, Jenny. This was great. So here goes. I got a little bit lost. I think I followed the argument. I'm on board with the feminist epistemological approach here, and I think it works really, really well. A couple of small questions, but the first small question is in the scenarios. So so scenario one, I guess it's just a clarifying question. Why is that a situation of forced sterilization, as opposed to, and help me think through this, something like, why is it forced? Because anytime any patient comes in, barring some other kind of information sharing that suggests the patient has another wish, most physicians would treat the patient for the medical necessity, and the justification would be presumed consent, right? Because you don't know. So is that really a case? That's kind of a crappy way to ask it. Help me think about the forced nature of that.
No, absolutely. That's a great question. So while trying to create the scenarios, I was trying to think of something that would be at least, how you say, I don't even know. It was really hard to create a scenario at all because it's hard to justify, forced anything in terms of medicine. So the reason why, I guess I didn't put the entire scenario, I more said it, but the person was in a car accident. They were brought into the emergency room, and they were not able to, so I specified they weren't able to communicate their thoughts, and they didn't have identifying documentation, so other people couldn't, help them, I guess, with consent. So the reason why it was so urgent was because I think it's because I identified it as like stage 2 ovarian cancer. And I did a little research, and, stage 2 doesn't seem like super far off, but it is like kind of immediate type stuff. And at least I guess I could have specified, in that time frame, possibly, this is a scenario where the person is being treated for all their other injuries as well from the car accident, and they're going to be in the hospital for a long time. But since they don't have anyone else to provide consent for them, they also can't provide consent for themselves. Therefore, who is going to make that judgment? The doctor is. It's forced at that point because there is no consent given by the patient.
Gotcha. Thank you. And I'll send more questions your way. We can talk about this. That's super helpful. So it's part of what makes it forced in this case is it's a medical determination, and the stage 2 matters. So I missed that. So that's helpful. So it's not just that the patient's going to die if they don't get procedure X, whatever it is in any case, right? Because I'm thinking about it generally, and it's an instance of forced sterilization, which you're focusing on here, because you could reasonable medical practitioners could disagree, and someone could say, no, we're going to wait on this because it's stage 2 or something. Good. That's super helpful. Thank you very much. Excellent. Again, the floor is open, and please just raise your hand with a little hand raising function if you'd like to ask a question for anyone or any of our presenters, and to keep me from asking people. Excellent. Yes, Vanessa again, please.
I just wanted to come on and like thank you for bringing this up to like awareness, because I remember reading this, and as a member of the Latinx community, I was in uproar when I heard this, because when this happened, it was almost like in the midst of the pandemic, so it kind of got shadowed by everything else that was happening. It's understandable with all the deaths and destruction that the pandemic led us with, and we're still dealing with it. But it's just like nice that these people have a voice now. Although this is a small presentation, who knows, one of us will go on and speak to this to the world, and we can bring awareness to really what's going on within our healthcare systems and what happened to these women to this day. Because I feel like at the end of the day, they were so vulnerable, not because they were immigrants, but because they had that language barrier also. So it was kind of like, it was heartbreaking to me, because my mom doesn't speak English. So I saw my mom within those women. So it was really like, so thank you. It was really interesting. And I also was kind of shocked to hear that somebody else actually knew about this, once again, because it was overshadowed by the pandemic. So it was like, wow, like there's actually people out there that kind of seek this out. So it was incredible. So thank you.
Thank you, Vanessa.
Vanessa, another very, very helpful comment. There are a shameless plug for the bioethics website at Seton Hall. We have a couple of wonderful student papers who are writing on this subject. I think they came out last year, so those are posted there, and I'm happy to share, or people can just sort of Google Seton Hall IHS Bioethics and it'll pop up. There's also a couple of papers in the Hastings Center on this, and the former director of Seton Hall's Latino Institute, Ano Campoverde, has published on this and connections to translation. So sorry, that's a lit review reading at you, but there's a lot of important bioethics work done in this area, but not enough. So thank you. Any other? Okay, I'm gonna jump in then, but people can sort of stick their hands up and keep going. And I'm just gonna go backwards through the presentation. So Jenny, that was wonderful. Brendan, you're not off the hook. So here's the question. Again, I said lots of folks say, medical historians, that the 20th century was the century of the surgeon. The question comes from this. Is it too easy? Not too easy. Is it, what kind of care must the surgeon take in trying not to do harm in this sort of case? So I think you did a nice job about highlighting non-maleficence, but sort of what kind of care does she or he have to take? And also, how does the surgeon properly informing the patient and the patient's family, right? Because you said it's usually younger patients, so they're not 18, they're not in the age of consent. How do you move forward as a surgeon if you don't get a unanimous decision? So that was a little rambly. Something about harm, and then what happens if it turns out the parents or the surgeon and the child say yes and the parents say no, or the parents and the surgeon say yes but the child says no, because they all seem, and you did a really, really nice job, I think, laying this out, they're all different stakeholders with different sort of power dynamic placements in the relationship. So help.
Sure. Thank you for the question. So in terms of non-maleficence, I think that the surgeon can first, make sure his techniques are up to par, when he's in the surgery, in the operation. I think that, you have to double check, that all of your normal techniques are up to par, so that there's no cases of, malpractice or anything like that, because obviously that would result in harm. Another thing would be to ensure that the patient has a dietitian following the surgery, and that you have, these sort of follow-up appointments to ensure that the patient isn't, gaining weight following the surgery, because, the whole goal of the surgery is to lose weight, right? So if you're gaining weight, I guess that would be harming the patient in a way, because, you're not helping them. So I would say those two things mainly. And then the follow-up question you had, if you could just repeat it for me, sorry.
So in terms of deciding, so that's helpful in terms of the frame of harm. In terms of deciding, you mentioned you needed a unanimous decision to move forward, which sounds right, but what happens in those instances of disagreement or even just different views, right? So the surgeon thinks, and so not great language, but the surgeon thinks the particular child is an excellent candidate for surgery, but the parents disagree that the child should have the surgery, though the child wants to have it. Or the surgeon has questions about the child's candidacy for surgery, but the parents and child want to have it. So there's some kind of disagreement between very different sorts of stakeholders in the conversation.
Okay, so yeah, so I think that you know, if the physician doesn't feel that the patient is a candidate for surgery, I honestly feel that the surgery shouldn't occur, because these qualifications are very specific. Like I mentioned, the 40 a BMI of 40 or a BMI of 35 and these other comorbidities, they have to be met, because there can be complications with surgery. Obviously it's better to lose the weight via natural means, or exercise and diet. So yeah, I honestly think in that case you would have to, listen to these qualifications. But in the case where you mentioned, I believe you said that the surgeon is uncomfortable about the surgery, but the parents and the child want to have the surgery, I believe you said. Yeah. Or actually vice versa, I believe you said. In that case, then autonomy, I believe, should be upheld. Like, you should inform the patient. There should be informed consent, but at the end of the day, autonomy needs to be upheld. That's my belief.
Excellent. Thank you. I'm now going to keep going backwards. I got a question for Chibeli, but I see a hand up. Perla, yes, please go ahead.
Hi, can you guys hear me?
Yes.
I actually have a question for everyone, but let's start with Chibeli. So, the topic was very insightful. I was extremely shocked with what Vanessa said about the climate. Everybody's worried about the state of our Earth, about our recycle, and everybody's pushing recycling, but nobody thinks about things like medical equipment to recycle. So do you think that the countries that are getting these donations, quote unquote, do you think that they are accepting these donations thinking that it's in good faith and they're using them properly? Or so to say, they're just accepting them because it's like a donation? Or do you think that they're really needing them but they need something else, but they're just accepting the donations? I don't know if my question makes sense. I'm thinking about how the poorer countries, for example, will accept the donations in good faith, but they won't, for example, do the background to check if they're very well done.
Yeah, thank you so much, Perla, for your question. That's a very loaded question. So I think for any donated piece of equipment, I think I'm going to reiterate what I said earlier. They have their own guidelines and code of conducts. So let's say for the Rotary International, they have guidelines and a checklist that each piece of donation has to go through before it even gets donated. So if the piece of medical equipment is being donated and it's not what the intended destination needs in particular, then I'm going to assume it's probably not going to get donated to that particular destination. Now, when it comes to the carbon footprint, the whole point of repurposing and reprocessing and donating medical equipment is to decrease that carbon footprint and the environmental impacts, because of course there are environmental impacts. When I was speaking to Dr. Pilkington last fall for this research, he did say that the whole point is to advocate for more reprocessing or just reuse in general for medical equipment. I hope that answers your question.
Yes, it did. Thank you.
Excellent. Perla, wonderful question, and Chibeli, a great answer. So I'll do the rude moderator thing, and I'll ask you a question, Chibeli, but ask that the answer be quick, because I want to get a question into Rishi before we wrap up in about 5 minutes. So it's really an invitation more than a question, to just say a little bit more about the notion of non-maleficence as you're sort of thinking through it in this project. And the reason I ask is I can imagine social stigma attached to reused items in general, right? And maybe this doesn't apply well to the medical equipment, that's fine. But so if there is stigma attached to it, I'm getting the leftovers, that kind of thought. Is harm occurring? Why not have efforts to actually just push brand new equipment elsewhere? Sort of, could you just say something about that? Does that question make sense?
Yeah, I get
Okay.
what you're trying to go for. First of all, thank you so much for your question. I think when it comes to non-maleficence, I think your whole intention is to not cause harm, which again, with one of my slides, it goes kind of hand in hand with beneficence. Like, yeah, you don't intend to cause harm, but it can still happen. It's still possible to cause harm to a patient or to whoever's going to be using the piece of medical equipment. When it comes to non-maleficence, though, like, I really have to think about that. I'm so sorry.
No, I was going to say, no, I think it's a tough question because in the background is that idea, and I think you made this super clear with the cleaning. And you had expressed this when you chatted before. There's a functional equivalency with the new tech and then the like recently new but reused tech, right? It's not you're getting my old Tandy 1000 versus a brand new Apple. Just computers, whatever your favorite computer is, right? So that's why I'm sort of stuck with the whether it's even a real issue or whether I'm just sort of making a bunch of or smoke when there's no fire or something like that.
I mean, it can also have something to do maybe with the society that we live in. Like, if, let's say we live in a capitalist society, it can come down to that as well. It really, with capitalism, you're looking more about the commodity. You're looking for the use value of the equipment. You're looking at how quickly and how efficiently you can produce this piece of equipment. That's a really broad question. I'm not even gonna lie, but I'm gonna assume it probably has something to do with that as well. Like, that definitely has an influence per se with this as well.
Excellent. Super helpful. Yeah, I mean, and as in any of these questions, we could talk about these topics all day. And a fitting sort of closing response from an anthropologist as well, which nicely connects up the different standpoints in the feminist epistemology that Jenny's working through. And also my final question, hopefully that's not too much of a non sequitur, to Rishi about his considerations of dignity and the different contexts in which it can be embedded. So Rishi, really, really nice job. We heard you at the beginning, your book ending. So we get you at the end as well. I was curious because you laid out Catholic considerations of dignity, broad points about healthcare, but mentioned that your roots are Hindu. So I was just curious if you could say something about dignity in Hinduism or what sort of drew you to connect Catholic thought and Hindu thought. So yeah, anything would be most welcome.
No, it's a great question. I just would say that the concept of human dignity is like those specific words are created by Catholicism, but in understanding, how it's based on the common brotherhood or the brotherhood under the common fatherhood, it's kind of similar to Hinduism in the sense that Hindus believe the same thing, where it's, when you die and you reincarnate, you go back to God and then you reincarnate into a new life. And in that way, you're always returning to God. In the same way, in Christianity, you'd be returning to heaven, or in Catholicism, you'd be returning to heaven. And so in that way, the respect that, that Catholicism has for the body as it is a gift from God is the same type of respect that is exemplified in Hinduism, because of that idea that we are gifts from God, and then we go back to God once we die. So in that way, it's almost a one-to-one, besides the actual term. And I go to a temple that's like a subsection of Hinduism, and so in that temple, we actually have a Human Dignity Day every October 11th where we celebrate. And what we do is we go out to just like neighboring families and we just talk to them. Not about like recruiting them to religion or anything like that. Like literally we just go to their house and we just talk to them and we get to know them. And in that way we spend time learning about other humans and their human experiences with no intention other than understanding another common brother. So it's a big part of our lives and it's almost a one-to-one basically.
Rishi, thank you. Super helpful and sort of raises some really important points in the dignity literature about intersubjectivity. I mean, there's all sorts of excellent stuff here. So thank you. We are just over our time. So I want to thank all of the presenters. Everybody in the audience knows it's not easy to hop up in front of people. And the level of sophistication, I'm getting all kinds of notes from all these presenters is not surprising to me because I spend time with them, but that's worth noting. So do the hand clap thing or whatever it is, the little emoji. The presentations were wonderful. We will save this recording. So if there are folks who have or interested in more, we'll have that for you. Thanks very much to Suli Chang, Professor Chang, who runs Petersheim, for being here, as well as we have guests from the medical school, the library, and other areas at Seton Hall. So it's really great to have everybody here. The students, you're all wonderful. And yeah, we'll look forward to the next bioethics event.